is dead, DSEK is dead, everything is dead, because there will be no problems in terms of shortage of tissue, because they replicate. So you can have one donor and you can replicate these cells for whatever, 100,000 people. Mm-hmm. But again, sounds like a bright future. Could turn out it's been phase 1A, a feasibility study somehow worked in a few patients, but it could be, another 10 patients, nothing going to work. But it also has to be considered in terms of investment in the technology. I think if you have the EndoArt now, you say, okay, the other thing, if it will ever come, ever work, we're talking about another 5 to 8 years, at least, if not longer. But for the time being, there's an alternative for the areas with shortage of corneas, and particularly for cases which perhaps already had failed grafts and so on. But it does not, at least at the moment, it does not appear to me as a permanent solution. To me, it appears as a temporary solution.
Would you, of course, you're talking about areas where there is a shortage of corneal tissue. For you, for example, if you see that the 5-year follow-up doesn't show corneal decompensation, would it have a role in your clinical practice?
Yeah, definitely. What we're missing at the moment is we also need studies on normal seeing eyes.
Yeah.
Because, why did DMAC basically displace DSEK? As far as concerned, only Americans still do DSEK. I do DSEK 3 times per year. Only in those cases like aphakic eyes where I don't think the DMAC is a good way to do. Because you do DMAC, it's a full, you rehabilitate the patients to the full extent. If the patient's macula is good and the patient can see or could see 2-3 years ago, 20/20, and you do DMAC, after 1 month, they're back to normal vision. It's like cataract surgery. It's like a miracle. With DSEK, they would not have we're not always able to see 1.0 20/20. They were 0.8, 0.6. So now the EndoArt has to compete with a technique that gives you the best possible vision. And these are the data that are lacking at the moment, because we know, yes, the edema goes away, but the corneal thickness decreases. But what we still don't know is, what about the visual acuity? So I think what they do need is to operate on a couple of eyes with full potential of visual acuity, and to see whether they will recover, or to what extent will the vision recover.
Mm-hmm. Yeah.
Just the thought, besides patients who would be suitable for DMAC, would there be a certain group of patients where you would, for example, see EndoArt being used rather than DMAC?
Not necessarily. Could be in some ways for me a good replacement for those cases where I still do DSEK. And I do DSEK in cases with very severe bullous keratopathy, and usually where we have no, aphakia, post-planar vitrectomy, which is much more difficult to handle the DMAC graft because you cannot decompress the anterior chamber. Yeah. So in my opinion, but again, these are not the big numbers. As I said, next week I've got again someone for DSEK, and I'm the only surgeon in my clinic who can still do DSEK. It's just because they're not enough for my younger doctors to learn it. So I say, okay, I don't care whether private, non-private. I do those couple of cases just because, you need to have a certain number even to keep up with the technique. Mm-hmm. So they're not going to get rich as a replacement for DSEK. But yes, it would be a possible indication for those DSEK cases where people like me, who otherwise would perform DMAC, would be very much prepared with patients with low visual acuity to go for artificial implant, because obviously it does have some advantages in terms there will be no rejection, it's easier to handle, and so on. but we also will require more study.